Welcome to Roadmap to Residency. Hello everyone, I am Aviras. Welcome to our Top to 50 Matchmaker sessions. We are currently in our nephrology modules, and this video is all about dialysis modalities and complications. So, which of the following is the most likely cause of the lightheadedness and muscle cramps experienced by this patient during and after hemodialysis? So, a 45-year-old man with end-stage renal disease secondary to long-standing hypertension is undergoing maintenance hemodialysis 3 times a week. He reports feeling generally well, but mentions occasional lightheadedness and muscle cramps during and after dialysis sessions. His pre-dialysis blood pressure is well controlled, and lab tests indicate adequate removal of waste products during dialysis. Which of the following is the most likely cause of the lightheadedness and muscle cramps experienced by this patient during and after hemodialysis? Dialysis disequilibrium syndrome, hypertensive emergency, volume overload, hypokalemia, or hyperkalemia. So dialysis disequilibrium syndrome is a complication that may occur during or after hemodialysis, especially in patients new to the procedure. It is characterized by neurological symptoms such as headache, nausea, vomiting, and occasionally lightheadedness. The syndrome is believed to result from the rapid removal of urea during dialysis, leading to osmotic disequilibrium and cerebral edema. Hypertensive emergency, the patient's pre-dialysis blood pressure is well controlled, making hypertensive emergency less likely cause. Volume overload and will typically present with symptoms such as edema and shortness of breath rather than the symptoms of the patient. Hypokalemia can cause muscle cramps, and it is not a common occurrence during hemodialysis, which typically removes excess potassium. Hemodialysis is designed to remove potassium from the body, and the patient is less likely to develop hyperkalemia during the procedure. So we need to understand the acute indications of dialysis, AEIOU, and these are very commonly asked in the examination. So A for acidosis, if the patient does have a pH less than 7.1, electrolytes, for example, if the patient is having refractory hyperkalemia, if there are any intoxications or ingestion like toxic alcohol, salicylates, or lithium, if there is volume overload, for example, in case of congestive heart failure, or if there is uremic pericarditis or uremic encephalopathy. So how dialysis machines actually work? We need to know this. So whenever we create a AV fistula, so the arterial blood leaves the arm towards the pump, and then it is mixed up with blood thinners to prevent clotting. So towards the pump, the dialysis fluid is there, and the pump is called as the dialyzer or artificial kidney. So the dialysis fluid, there is a change of the substance, the toxic substances through osmosis or something, and then the dialysis fluid carrying the waste product and urea is removed, and again the blood is clean, the clean blood is again then sent back to the body, and the clean blood returns to a vein in the arm. Okay, so this is the basic principle of how dialysis machines actually work. So there is AV fistula, there is dialyzer, and there is the dialysis fluid, and there is exchange of the substances. Okay, so what are the complications of dialysis? So you know that there is something called hemodialysis, and there is another mechanism which is called as peritoneal dialysis. So hemodialysis, the complications include dialysis disequilibrium, just like we have seen now. There is filter rupture. There is clotted filter if we cannot use adequate amount of anticoagulants, hypotension, cardiac arrest, air embolism, hemolysis, water contaminations, allergic reactions, excess hemorrhage, and bloodstream infection. In case of peritoneal dialysis, the most common is peritonitis. There is exit site cellulitis, outflow failure, catheter leak, intestinal perforation. There can be PD-related hydrothorax. There can be encapsulating peritoneal sclerosis, membrane failure, weight gain or hyperglycemia, or in some cases, hypoalbuminemia. So, which of the following is the most likely explanation for the cloudy peritoneal effluent in this patient on continuous ambulatory peritoneal dialysis? A 50-year-old woman with end-stage renal disease secondary to polycystic kidney disease has opted for peritoneal dialysis as a renal replacement therapy. She has been on continuous ambulatory peritoneal dialysis for the past 6 months. During a routine clinic visit, she reports occasional cloudy peritoneal effluent. She denies any abdominal pain, fever, or other associated symptoms. Which of the following is the most likely explanation for the cloudy peritoneal effluent in this patient on continuous ambulatory peritoneal dialysis? Peritonitis, catheter dysfunction, inadequate dwell time, hyperglycemia, or protein leakage. So the most likely explanation for cloudy peritoneal effluent in a patient on continuous ambulatory peritoneal dialysis is peritonitis. Peritonitis is common complication of peritoneal dialysis and presents with cloudy effluent, abdominal pain, fever, and other signs of inflammation. So you may be confused in between the protein leakage. Okay, so protein leakage may occur in peritoneal dialysis, but it typically presents with milky appearance rather than cloudiness. Similarly, for hyperglycemia, while hyperglycemia can be a concern in patient on peritoneal dialysis, it is not a direct cause of cloudy effluent in this patient. So peritoneal dialysis, so it is a method of renal replacement therapy. So the peritoneum, there is capillary endothelium matrix and mesothelium, which is a semi-permeable dialysis membrane, which acts as a semi-permeable dialysis membrane through which fluid and solid move from blood to the dialysis solution via diffusion and convection. The effective peritoneal surface area is equals to the perfused capillaries closed to peritoneum, which is decreased in case of peritonitis, and there is defect in the peritoneal dialysis in case of peritonitis. The ultrafiltration, that is the movement of water, is enabled by the osmotic gradient generated by glucose or glucose polymers, also called as isodextrin. So, which of the following complications of dialysis is the most likely cause of the patient's presentation? 60-year-old man with a history of diabetes mellitus, again, and end-stage renal disease, undergoing hemodialysis, presents to the emergency department with sudden onset chest pain and dyspnea during a dialysis session. He is diaphoretic and his blood pressure is 80/50. The dialysis session is promptly terminated, and ECG shows ST segment elevation in the anterior leads. Which of the following is the complication of dialysis is the most likely cause of this patient? Dialysis disequilibrium syndrome, intradialytic hypotension, dialysis-associated amyloidosis, hemolysis, or dialysis catheter-related infection. So intradialytic hypotension is a common complication of hemodialysis, which can present with symptoms such as chest pain and dyspnea. It is characterized by a sudden drop in the blood pressure during or following a dialysis session, and potentially leading to inadequate perfusion of vital organs. For example, in our patient, it was causing angina. So, which of the following best describes the likely cause of the patient's symptom during dialysis? Again, a 55-year-old man with newly diagnosed interstitial renal disease secondary to hypertensive nephropathy is initiated on hemodialysis. And during his first few sessions, he experiences headaches, nausea, and generalized discomfort. Again, the symptoms occur towards the end of each dialysis session and improve with rest. His blood pressure drops significantly during the session, and there is no evidence of infection. So which of the following is the cause? Dialysis catheter-related infection, intradialytic hypotension, dialysis-associated amyloidosis, dialysis disequilibrium syndrome, or hemolysis. So, yeah, as you all have figured out by now, dialysis disequilibrium syndrome comes with CNS symptoms. Okay, it can generally occur after the first few sessions of dialysis, and it typically occurs during or after the first few dialysis sessions, especially in patients with rapid reductions in the blood urea nitrogen. The symptoms are believed to result from the rapid removal of urea from the central nervous system, leading to cerebral edema. So what is dialysis disequilibrium syndrome? So it is an acute neurological condition, and it is a consequence of rapid hemodialysis, where the osmotic gradient of brain versus plasma, which can cause the cerebral edema. So there is when there is rapid expulsion or rapid excretion of urea from the brain, then there is osmotic dysfunction, which can cause cerebral edema. And the risk factor is generally first session hemodialysis, extreme age, for example, child or extreme old age. If the patient has high BUN level that is more than 125, so when there is high blood urea, and then more of the urea is removed, and when more of the urea is removed, there is more osmotic disbalance, which can cause more of the cerebral edema. Or if the patient has some CNS disorder like stroke, tumor, or dementia, then it can also predispose dialysis disequilibrium syndrome. The common symptoms include CNS symptoms like headache, nausea, and vomiting, and in some cases, seizures and coma can also occur. So the urea concentration in brain is higher than the blood. There is slow transport, and water from the plasma flow into the extracellular space, causing extra pressure. And this all can lead to cerebral edema, which can cause the symptoms of the dialysis disequilibrium syndrome. It is prevented by keeping the dialysis efficacy as low as needed. Thank you for watching. Keep studying.